Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss about ECG in emergency room. How to read ECG in emergency room. You know that ECG is one of the most important tool in emergency room. Not only in cardiac diseases, there are a lot of other related diseases or some other diseases like electrolyte imbalance. All these conditions we can use ECG as a tool. So you know that ECG is taken with 12 leads in your ECG paper, but we can see how we are connecting the limb leads here. One is in the AVR, AVL, left foot, and chest leads. So these are limb leads. These are chest leads. Okay, we'll not discuss that now. We'll see while taking ECG. We'll see each lead separately. There are 12 leads in your ECG. If you can see here, 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Like that, 12 leads are there. You take only AVR. What is happening in AVR you have to see. All the complexes in AVR will be negative. Okay, P wave will be negative, QRS will be negative, ST segment will be normal, and T wave will be negative. That is because you can see here the electrical axis from, if you are taking right upper limb AVR, the electrical axis will be from right to left. So the current goes away from the vector. That's why you get all the complexes in AVR has to be negative. If they are positive, then you have to think that these limb leads are interchanged. Okay. Otherwise, AVR has to be negative. So AVR, you see all the complexes will be negative, whereas lead 1, lead 2, lead 3 all will be positive. AVR, AVL also will be positive. 2, 3 AVF indicates inferior wall. 1 and AVL indicates lateral wall in ECG. V1, V2 is septal. V3 and V4 is anterior leads. V5, V6 is lateral. You can see here 1 AVL and V5, V6 will be lateral. These are the categories of leads which are placed during ECG reading or ECG taking. So we'll see each changes separately. So before starting ECG, you have to always identify two important problems or two important analysis to know whether the ECG is taken normally or not. One is the standardization. So every ECG when you take, you can see this standardization ECG paper, then only you get QRS complexes like this. Okay. So this will be 10 small square height and 5 small squares width. So you can see here 2 boxes or 10 small square height and 1 large square or 5 small square width. So that is very important. Before starting reading the ECG, you can see that. Next is, I already told, AVR. AVR is looking the heart from the right side. The electrical axis will be towards left. So it sees the heart from right side and electrical current is going away from the vector. So all the complexes will be negative. That is very important. So AVR you can see here, everything will be negative, whereas AVL and AVF will be positive because AVL connect on this side, AVF connect on this side, and current is coming towards this vector. So it has to be positive. Now if you see the ECG paper runs in a speed of 25 millimeter per second. If you see the duration of each small square, it is 0.04 second That is 1 millimeter square is equal to 0.04 second. 1 big square, so you can see here 5 small squares will become 1 big square. 1 big square is, that is 5 millimeter, 0.2 seconds. 5 big squares are 25 millimeter or 25 millimeter or 1 second. 30 big square are 6 seconds. Height of 1 big square is 0.5 millivolt. All these things are useful when you are calculating the rate, rhythm or LVH, all these things. Okay. Now we'll see, I'll give a glance of the conduction system here. So electrical activity is like this: SI node. From SI node the electricity go to the AV node. Then from there it will go to the bundle of his. Then it spreads to the right side and left side. Okay, the electrical activity in the conduction system will be running like this, and SI node activation produces P wave. The time taken from SI node to AV node is PR interval. PR interval is starting from P to the starting of QRS complex. Then the bundle of his is marked as QRS complex. Okay, so you can see here atrial depolarization, that is P wave. PR interval is the time taken from the P wave to the QRS complex. Ventricular depolarization is QRS complex, and ventricular repolarization is ST segment and T wave. Okay, so these are the complexes you see in a single ECG tracing. Now there are 3 modern waves in ECG. One is P wave, that is atrial depolarization. One is QRS complex. In that Q is there, R is there, S is there. That is ventricular depolarization. Then T and ST segment is ventricular repolarization. That means during atrial depolarization or activation of atrial current, P wave is produced. Every P wave has got a PR interval. Then PR interval will be followed by, or P wave will be followed by a QRS complex, and regularly you see R waves. Okay, that is called as RR interval. Okay, RR interval. Now here you see any ECG we take, whatever may be the condition, we have 12 leads, and the last part of the ECG you can see a long rhythm strip that is normally taken in lead 2 because P waves are very visible there. That is the reason. Okay, you can take any lead, not an issue, but P waves are clearly seen there. That's why we are taking lead 2 as the rhythm strip. So always check the standardization. Next, see all the waves in AVR is negative. Then check for the rhythm strip. Now, what is normal sinus rhythm? When we are palpating the pulse, we always tell that when the pulse is regular, we tell pulse is in sinus rhythm. But in ECG wise, it is not like that. Every SI node activation will be followed by a P wave in the ECG. Then the time taken from the SI node to AV node will be PR interval. So from the P to QRS is PR interval. Then ventricular activation occurs, you get QRS complex. Then repolarization, you get T wave. But this has to continue. Okay, again P wave, PR interval, QRS complex, T wave, again another P wave, like that. Okay. So what is sinus rhythm? Sinus rhythm means you need to have a normal P wave, normal PR interval. I'll tell what is normal PR interval. Then you need to have a QRS complex after every P wave. That means every activation of SI node will be followed by an activation of AV node. Then the RR interval has to be equal or regular. So this is called as normal sinus rhythm in ECG. So it is very clear. Normal sinus rhythm means normal SI node activation with a P wave. The PR interval is normal. I'll tell what is normal PR interval. Then every P wave should follow by a QRS complex. RR interval has to be normal. That is normal sinus rhythm. Now how to calculate, when you tell that sinus rhythm, immediately next step will be calculation of the rhythm. So sorry, calculation of the rate. So there are easy methods to calculate the rate. One is, you can see the largest squares here, 1, 2, 3, 4. 300 by 4 will give the answer 75. 300, suppose it is 5, then 300 by 5, that will be around 60. If it is 6, 300 by 6, that will give 50. Okay, but you can get a better value by doing another method, that is 1500 by number of small squares. You can see here, each large square has got 5 small squares. So suppose you have 5 squares, then it will become 5 into 5, 25. So 1500 by 25. That will give you the answer. Okay, both ways are good, but most of the latest ECG machines will give the report. They'll tell what is the rate in a sinus rhythm. Now, can you calculate the rate here? It is very simple. You count the number of large squares here. 1, 2, 3, 4, nearly 5. So 300 by 5 is 60. Since it is normal sinus rhythm, we can calculate like that. It is 60. Now, if the rhythm is irregular, you can see here RR interval is totally irregular. So that is atrial fibrillation. You will learn what is atrial fibrillation afterwards. So there, the other method is not possible, because here it has got 1, 2, 3, 4, 5, 6. But here only 1, 2, 3, 4 is there. So it varies, because RR interval is varying. It varies. Okay. There another method is there. You can take the 6 second. 1 second is 5 large squares. So like that you take 6 seconds. In that 6 seconds, how many QRS complexes are coming? You can see 1, 2, 3, 4, 5, 6, 7, 8. 8 into 6 seconds you get 8. 60 seconds into 10 you get 80. So that will be the rate. Okay. But don't worry, most of the newer ECG machines will show the rate. We no need to calculate. Now there is something called as intrinsic rhythm. There is actually an intrinsic rhythm for your SA node or AV node. Suppose SA node produces a rhythm, your pulse rate will be somewhere around 72, 75, 76, like that. But if due to any reason SA node is not working, then AV node will take over the function. The rate will be somewhere around 60. If AV node also not working, then ventricle will take over the function. The rate will be 40. So wherever there is block, the next level will take over the function, so that heart will not stop. Now normal rate is somewhere around 60 to 100 beats per minute. Then if the heart rate is less than 60, or some books say it is less than 50, then you can call it as bradycardia. If the heart rate is more than 100, you can call it as tachycardia. But if the heart rate is more than 140, you can call it as supraventricular tachycardia. We'll see all these things afterwards. Now we'll analyze each waves. First one is P wave. SA node activation, the electricity from the SA node will produce a P wave. And that is very important. That you should understand. The normal P wave in ECG represents electrical depolarization of the atria, or the electricity starts from the SA node. Then electricity goes to the AV node, there you get QRS complex. Now, I have already told why we are taking rhythm strip in lead 2. That is because we can see the P wave properly there. Okay, that's why we are taking rhythm strip. There, if you see the P wave, you can see the P wave height and width. For easy understanding, you can just remember it is 2.5 large square height, 2.5 width. Okay, so a normal P wave, small squares. A normal P wave can have maximum 2.5 division height and 2.5 division width. Okay, so if it is more than that, the height is more than that, it is abnormal. The width is more than that, it is abnormal. We'll see what are the abnormalities. Now what you are seeing is, here is there are two important types of anomalies seen in P wave. Here what we have already seen is the height is more than 2.5 divisions. Here how many are there? 1, 2, 3, 4, 4.5. So that height is more than 2.5 divisions. Whereas here the width is maximum is 2.5. So here width is 1, 2, 3, 4, and we are getting a notch in the P wave. This P wave is very peak P wave. Okay. So peak P wave or tall P wave more than 2.5 divisions is called as P pulmonale. Okay, P pulmonale. Okay, this is classically seen in right atrial enlargement. This is the classical finding you see core pulmonale due to COPD or any lung disease. Any lung disease leading to right atrial enlargement, right ventricular enlargement, that is called as P pulmonale. Okay. Here you get a, so remember peak to P waves, P pulmonale, core pulmonale. Okay. Here P waves are having a M pattern. Okay. So this is called as P mitral, M for mitral, P mitral. This indicates left atrial enlargement. This is classically seen in left atrial enlargement due to mitral regurgitation or mitral stenosis. So mitral valve lesion produces left heart and left atrial enlargement. This is called as P mitral. Now even in lead V1 you can see P waves. There the P wave has got a biphasic appearance. Normal P wave is like this here, but whereas in lead V1 it has got a biphasic appearance. And P pulmonale, the first part of the P is tall, P mitral, the second part of the P is weak. Okay, so even lead V1 you can see all these findings in a different style. Now what is this ECG? You can see the ECG here. The P waves are very tall. Suppose this patient is having a chronic COPD or interstitial lung disease, you will make a diagnosis of core pulmonale. This ECG change is called as P pulmonale. It is due to right atrial enlargement. Okay, so very tall peaked P wave. Okay, peaked P wave. Now next ECG, what you are seeing is, you can see here, the P wave has got a notch in between. Okay, and it is wide also. Width is more than 2.5 divisions. This is called as P mitral. This patient may have a left valvular disease, mitral regurgitation or mitral stenosis, leading to left atrial enlargement. Now another P wave important change is multifocal atrial tachycardia and atrial fibrillation. Since SI node, every time SI node produces P wave, the morphology of P wave is always same. But remember, SI node produces one, another is coming from another direction, another coming from here, this from here. So first one will be like this, second one will maybe like this, third one will be like this, fourth one will be like this. So different morphological P waves. This is called as multifocal atrial rhythm. If the heart rate is more, we call it as multifocal atrial tachycardia. This is a classical finding you see in hypoxemia. Now second change is, you are not able to see any P wave, but the baseline is wavy and you get QRS complex and the RR interval is not equal, unequal. Okay. What is happening here is, normally SI node to AV node conduction occurs, it go to the bundle and like this, but here there are multiple focuses. They all fire electricity in a rate of more than 600 firing per minute, and all the 600 will never go to the ventricle. Around 140 to 200 may go to the ventricle in a irregular manner. That's why you are getting irregular QRS complexes and the wavy baseline. Baseline is wavy because it is not single focus, multiple focus. So this is called as atrial fibrillation. Now what is atrial fibrillation? I already explained. Normally SN note, AV note, only one conduction is there, only one P wave is there, and PR interval is there. But here in atrial fibrillation, multiple foci produces current like this. Everywhere current is coming, so there is no proper P wave. We get a wavy baseline, and from that one may go to the ventricle, that produces QRS. Again another wavy baseline. But look at this RR interval. RR interval is highly unequal. Now next is PR interval, the time taken from the onset of P wave to the QRS complex, that is from the SA node to AV node, time is taken. So that is PR interval. Normal P wave is maximum is 2.5 divisions. Here it is from here to here, maximum is 3 to 5 small divisions. That's all. Okay. So you can start from here to here, 1, 2, 3, 4.5 divisions. That is a maximum. If it is more than that, the time taken from the SA node to AV node is more. If it is less than that, there is an accessory pathway which is faster and conduction is faster. That's all. The normal PR interval is 120 to 200 milliseconds, that is 3 to 5 small squares. If it is prolonged, there is first degree heart block, more than 5 squares. If it is narrow, then there is an accessory pathway. This is called as Gould-Parkinson-White syndrome. Now short PR interval is always called as WPW syndrome. Normally SA node, AV node conduction is like this. But if there is an accessory pathway, the conduction either this side or this side will be faster. So PR interval will be shorter. Okay. Whereas there is a conduction block in first degree heart block, SA node, AV node, it takes like this. P wave, PR, QRS complex like this. But if there is a conduction defect, conduction is low, what happens? P wave is there. Takes a longer time than you get the QRS. So PR interval is prolonged. Okay. This is called as first degree heart block. Now PR segment, it is not that important for a basic ECG reader, but if you know something about pericarditis, myocardial infarction, all these things, then this may be helpful. Normally, you get P, PR interval, QRS complex, ST segment, T wave. So you can see here, PR segment and ST segment are in same line, But if the PR segment is elevated or depressed, then that is significant. PR segment depression is seen in acute myocarditis, pericarditis. PR segment elevation also can be seen in pericarditis and even in atrial ischemia. So acute pericarditis, you can see the PR segment depression. Acute atrial MI and pericarditis, you can even see PR segment. It is not PR interval, PR segment elevation or depression. Not that important. Now next is QRS complex. You can see here a small q, then R, S. This is Q, R, S. Depending on the leads, it can vary. So sometimes Q can be deeper also. Sometimes there is no Q, only R can be there. That depends on the lead electricity, it can change. So this QRS complex represents ventricular depolarization. Normal width is less than 120 seconds or less than 3 squares. So suppose these are the squares, small squares. QRS complex should come like this. But whereas if the QRS complex is like this, wider than 3 divisions, then you can call it as QRS complex is wide. Normal QRS, wide QRS. Normal QRS, it is less than, here it is 2 squares are there, 2 squares. Wide QRS, 1, 2, 3, 4, because it ends here. So 4 squares are there. Okay. So normal QRS means it is going through the regular pathway. Wide QRS complex means there is some problem in the conduction. That's why it is delayed. That's why the QRS complex is widened. Now, when you are talking about wide QRS complex, there are 2 important conditions you should remember. One is RBBB, other one is LBBB. You know that SA node to AB node conduction, then you have bundle. Okay, right bundle and left bundle. If there is a block in the right bundle, you call it as RBBB, and if there is a block in the left bundle, you call it as LBBB. Right bundle branch is not that important because most of the time you can see right bundle branch block in many normal male individuals, but LBBB is always significant. You can see in RBBB, you take V1 first lead. There is a pattern R, small r, then S, then R dash big R, and ST depression and T inversion. So small r, then S, then R dash, then ST segment, depression, T wave inversion. This is classically seen in V1. Okay, so that is called as RSR dash pattern, RSR dash pattern. Whereas in LBBB, you look at the sixth E6 lead, get either M pattern, you can see here M pattern, or sometimes you can get W pattern. Okay, if M pattern is there, the ST segment will depress and T will be a negative. If it is W pattern, this will be upright. This is called as discordancy. Okay, M is upwards, T is downwards. Here W is downwards and T is upwards. Okay, whatever it is, common scenario is you get an M pattern in V6. Okay, that is LBBB. LBBB is always dangerous and it indicates ischemic heart disease. There are some other conditions, rate limited LBBB, hypertensive heart disease, ventricular dilatation, all these things also you can get. But as a beginner, you should always think that LBBB in acute settings is myocardial infarction. Now here you can see RBBB pattern. You take the V1, I already told R, S, R dash pattern. So R, S, R dash pattern is RBBB. It is not that important ECG finding. Many of the normal individuals you can get this finding, so that is not a big problem. And QRS complex is wide here, like we told in the previous slides, it is wide. Now LBBB is always dangerous. You can see 2 important patterns. One is M pattern or W pattern. So in V6 alone you see, here it is M pattern, ST depression, T wave inversion. Whereas W pattern will be same like this, W pattern, ST elevation. ST elevation may not be there, T wave upright. Okay. So this is called as discordance. Means QRS will be one direction and ST segment and T will be another direction. So look at the V6. Wolff-Parkinson-White syndrome, I have already told, it's a wide complex rhythm. That is, we already told in the previous slide, PR interval is short. That is because you have your ventricle, atrium and ventricle. Normally electricity goes like this, but in some condition there will be an accessory pathway. Either it will go through this accessory pathway upwards or downwards. This is a faster pathway. So you get a short PR interval, then you get a slurring of upsloping of the ST segment. This is called as delta wave, and you can get a wide QRS complex ST segment TO inversion. This is called as delta wave. So this is WBW syndrome. Here also you get wide QRS complex. Next is Q wave. Q wave mostly indicates an infarct. So normally what you see is a Q, R, S pattern. This is QRS. Q, R, S or R like this, capital R. But what happens in ischemia? It will produce a negative window because of ischemia. You get a large Q wave and you get a small R wave. That's all. So this Q is larger. So a significant Q wave is due to infarct, and Q wave must be at least one small box width wide and 1/3 of the entire QRS complex. That is very important. So Q wave is always indicates a previous ischemia. It may not reflect an acute disease. A patient had myocardial infarction, that part is dead, that's why you are getting a negative window, you are getting a negative complex. Now old infarcts, that is always, we already discussed old infarcts. Here you can see QRS, so the complex is like this, Q is there, then there is R wave, so a large Q. Large Q always indicates infarct. Here where we are seeing the Q wave? Lead 3, we are seeing V1 it is there, QS pattern, V2 it is there, V3 it is there, V4 it is there, V5 it is there, V6 it is there. All the anteroseptal leads are got old changes. That indicates previous myocardial infarction in the anterior leads. Whereas this ECG shows 2 there is Q wave, 3 there is Q wave, and AVF there is Q wave. That is inferior wall, old myocardial infarction. Okay. Now next is ST segment. This is produced by ventricular systole. During systole, you get this wave, and it is normally in an isoelectric line. That means P is there, PR segment is there, QRS is there. Then your ST segment drops in the same line with your PR segment. Okay. If it goes above, you call it as ST segment above, elevation. If it goes below, you tell it is ST segment depression. So here you can see ST segment elevation, here you see ST segment depression. Normally it is in the isoelectric line. Okay. Now ST segment elevation. Whenever you see ST segment elevation, you always suspect myocardial infarction. For example, somebody is coming with severe chest pain, left-sided chest pain. You are seeing the ECG, and ECG shows V1 to V4, ST segment elevation. That is anteroseptal myocardial infarction. That is acute. Whereas if you are seeing ST segment elevation in lead 2, 3, and AVF, then it is mostly inferior wall myocardial infarction. I have seen which are the areas represented by the leads. So where all you get change, you can diagnose ST segment elevation. That leads you can make a diagnosis of myocardial infarction of that area. Now what is ECG? This ECG shows ST segment elevation in slide 1 in V1, V2, V3, V4, V5, V6. If the patient is having severe chest pain, that indicates myocardial infarction. Okay. So where is the infarction? It is in the anterior wall myocardial infarction. Since it is anterior placed leads, you are seeing ST elevation. This can be anterior wall myocardial infarction. There are multiple other reasons for ST segment elevation that I will tell afterwards. Here you are seeing ST elevation in lead 2, lead 3, AVF. So this is inferior wall myocardial infarction, and you can see one important change, that is ST segment depression in V1, V2. ST segment is depressed here. This is called as reciprocal change. If there is ST segment elevation V1, V2, that's anterior myocardial infarction, you can get similar ST segment depression in the inferior leads also. This is called as reciprocal changes. Actually, here the problem is ST elevation in 2-3 AVF that produces reciprocal changes there. That's all. Now, whenever you are seeing inferior wall myocardial infarction, always remember to take right-oriented leads, because most of this inferior wall MI, that is 30 to 40% of inferior wall MI, can have associated right ventricular myocardial infarction. So here you can see ST segment elevation V1, that is right-oriented lead. ST segment elevation lead 3 more than lead 2. Lead 3 more than lead 2. Okay. We will not discuss all these things, but take a right-oriented lead if you get a inferior wall myocardial infarction. Now, coronary circulation, and I am not going to the details of this circulation, this is only theory. Whenever you are getting ST segment elevation in one AVL V5, V6, it is lateral wall MI, circumflex artery, 2-3 AVF, inferior wall, right coronary artery, V1, V2, septal, left anterior descending artery, V3, V4, anterior wall, left anterior descending artery. These are the common arteries involved. Now, ST elevation can also be due to, so we are told myocardial infarction. The elevation can even because of pericarditis, normal variant. This is called as early repolarization. We are not discussing all these things here. For an average MBBS doctor, if ST elevation is there, severe chest pain is there, it is myocardial infarction. Now T waves. Now we have already discussed T wave, PR interval, QRS complex. T wave is always upright. Okay. If it is very tall, it is problematic. It is inverted, then also it is problematic. So you can see here normal T wave, very tall T waves in all the leads, most of the leads, then it may be due to hyperkalemia. If the patient is having renal failure, very tall T waves are seen in all the leads, you can suspect hyperkalemia. But if the patient is having particular leads like V1 to V4 only, then you have to suspect hyperacute myocardial infarction. If the T waves are inverted, both the limbs are equal, then it is due to ischemia. In strain pattern, that is LPH with strain, one limb will be larger than the other limb. This is smaller, this is larger. Okay. This is called a strain pattern. Now, very tall T waves always indicates hyperacute MI if it is seen in all the leads. Hyperacute MI only in a group of leads. Hyperkalemia, it is universal tall T waves, all the leads. So you can see here, only few leads you get very tall T waves. That is because of anterior wall MI. Whereas in this ECG, all the leads we are seeing very tall T waves. Okay. So this is due to hyperkalemia. That is the difference. Now, T wave inversion always indicates ischemia. Normally we see T wave, QRS complex, and T upright. But here what is T, QRS complex, T is upright, down. Okay, both the limbs are equal. Then you have to suspect ischemic heart disease. That is very important. So suppose in this ECG you are seeing V1, there is T wave inversion, V2 it is there, V3 it is there, V4 it is there, V5 it is there. So it is anteroseptal ischemia. If the patient is having chest pain, it will become unstable angina. Now LVH with strain, okay, there also you get T wave inversion, but what we learned is ischemia, both the limbs will be equal. LVH strain will be, one limb will be deeper, other limb will be like this. Okay. But what is LVH with strain? Because of left ventricular hypertrophy, you get very large ECG complexes. You can see the QRS complex here and here. This criteria is called as Romil test is criteria. You can read that. I am not going to the details of that. You calculated the number of large squares in V1 S wave, that is for V6 R wave. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 into 5, 50. So more than 35 small squares. More than 35 small squares. So here. That is it. Okay. If you add these two, more than 35 small squares, then it is diagnostic of LVS, and strain pattern is asymmetrical. RVH is just opposite that. There will be prominent R waves in V1. Normally R wave morphology is small V1, small R wave here, deep S wave. Okay, but what you are seeing here is slightly different. You don't see that you get a very tall R wave. Tall R wave. Okay. So that is seen in right ventricular hypertrophy. A dominant R wave in V1 more than 7 small squares. That is very important. Axis, I am not going to the axis in detail here. Only thing, very important things I will tell you. You take lead 1 and ABF or lead 3. If QRS complex is negative in V1, positive in lead 3, if both are reaching towards center, that is right axis. Reaching towards center, that is right axis. Here you see lead 1 is positive, lead 3 is negative. Leaving away from the center, that is left axis. This is the simplest way to understand the axis is turned right or left in the heart. If both are coming towards the center, reaching towards center is right axis. Leaving away from center is left axis. So here you can see, here you can see. Okay, so that is left axis. So we have completed one part of the ECG. The other part will start soon. There we will discuss how to manage tachyarrhythmias, bradyarrhythmias, and heart blocks. That will complete the ECG Masterclass. Thank you.